So moving on to next session. The next session is a panel discussion on unmet needs in management of alcohol-associated hepatitis. So the chairpersons for this session are Dr. Tarun Kumar, Dr. Akshay Kale, Dr. Aval Sadikot, Dr. Saurabh Bansal, and Dr. Amit Joshi. Panelists are Dr. Amit Goyal, Dr. Sandeep Bhagat, Dr. Nirmal Yadav, Dr. Ashwini Kumar, Dr. Sudhir Gupta, and the speaker is Dr. Ashwini Singhal.
Good afternoon, and at the outset I'd like to thank Anil and his team for putting together this year after year excellent clinical meeting for 2 days, which I've been thoroughly enjoying since yesterday. So the topic he gave me is alcohol-associated hepatitis, what is new, and it's partly, I think, covered to some extent by Dr. Epan about plexin, decompensated alcohol-associated liver disease, and alcohol hepatitis. So what I'm going to do over the next 30 minutes or so, before I take questions with the panel, the esteemed panel, is to spend time on how to manage alcohol use disorder in patients with ALD. So that will be the focus of the talk. And here are the disclosures. None is relevant to the presentation. And I take up this case because Anil specifically asked me to do a case-based presentation. So I take this case which we published in Gastroenterology, and I'll take you through the journey. I cannot go through the whole scenario of this case, but just focusing on the alcohol use disorder. So the case starts like this. This is a 34-year-old female seen for a new diagnosis of liver disease. She was hospitalized after a fall. She was obviously having signs of alcohol withdrawal. And then she has a comorbidity of obesity. Alcohol use was there about 2 to 3 drinks per day, which is about 15 to 20 drinks per week since she was 16. She's had several healthcare encounters before this admission, including one with a gastric bypass procedure 4 years ago, and she lost 65 pounds and a current BMI of 28. You can imagine the BMI at the time of surgery. So the question comes to mind, what do you think is the cause of a liver disease, presuming that other serology of liver disease are negative? And I bring this new nomenclature 2-3 years ago, which we all are aware of and may have seen during this meeting a couple of times. And the red box tells you this is what the patient had. She was obese, which is a metabolic syndrome, and her alcohol use qualifies to a diagnosis of MET-ALD. But that's not the point here on this slide. The point I want to make here is look at the overlap between MET-ALD and ALD. It's so hard to differentiate a MET-ALD patient from a predominant ALD patient. And that becomes even difficult because patients don't report accurately the alcohol use. Patients have a recall bias about alcohol use. And the slide on the left shows you, even in clinical trials, the misclassification based on the amount of alcohol use. You can go from MASLD to MET-ALD and MET-ALD to ALD and vice versa, is about 10%. In clinical setting is about 55%. Very nice editorial by Alexander. Comes to rescue is a biomarker of alcohol metabolism, which is phosphatidyl ethanol or PEth. At a cutoff of 20 to 25, you can separate MASLD from MET-ALD. And at a higher cutoff of about 200 nanograms, you can separate MET-ALD from ALD. But the patient has to be actively drinking until a few weeks prior to the presentation. The another issue is, in a clinical trial and in a clinical setting, is the disease state transitions. And these data are from one of my close friends, Dr. Robert Wong, who presented these data at EASL meeting this year. And the slide shows you, for the purpose of the talk today, this is the MET-ALD. Over a period of 8 years, and these are all veterans, males patients, about 40% of these patients who were classified at the beginning to have MET-ALD, over time their alcohol use decreased and they could be classified as MASH LD. On the contrary, about 14% of these patients increased their alcohol use and was classified as alcohol-associated liver disease. And this is relevant because over time, what would happen to the patient, and I'll show you how this patient transition into cirrhosis, is the risk of cirrhosis increases if they transition into a higher intake of alcohol and into a phenotype from MET-ALD to ALD. The another issue which is highlighted in this patient is she underwent a gastric bypass surgery, and there is a lot of data available now, mostly observational retrospective data, to show that at year 4 and year 5, after gastric bypass surgery, not only alcohol but other drugs and substance use increases in patients for some reasons who undergo gastric bypass surgery. And the control population here is sleeve gastrectomy in the middle and MOVE program, which is just lifestyle intervention on the left. And compared to those two ways of weight loss reduction, the gastric bypass at year 4 and year 5 are more likely to have audit 2 or audit 3, which is more severe alcohol use disorder patients. So the second question comes, could and how the liver disease in this patient be prevented? You know, this patient had so many healthcare encounters, including gastric bypass procedure, and what was missing in this patient is we failed to identify this patient at risk of developing liver disease over time. And this is a nice study, again from Denmark, Danish registry, showing you a 15-year retrospective follow-up on this 36,000 odd patients were followed for about 20 years or so, 1988 to 2002. And 6% of those developed cirrhosis after 15 years. But majority of them had some kind of healthcare encounter in the preceding 15 years where there was an opportunity to identify a high-risk alcohol use, screen for liver disease, and maybe prevent cirrhosis down the line. And how you do that, once you identify high-risk alcohol use, and we are aware of the serum markers, the FIB4 and the enhanced liver fibrosis score, and the radiological markers, which is FibroScan or VCTE and MR elastography. For F3 or higher fibrosis, there are score cutoffs, the lower cutoffs where you can rule out F3 or below, and a higher cutoff where you can make a diagnosis of F3 or higher. Similarly, the cutoffs are available for cirrhosis. For sake of time, I would not go into those details here, but the numbers are written over here and the references down there for your own reading. So this is an important slide, how to identify high-risk alcohol use, and I think I'd like to spend time a little bit here is what is called SBIRT, which is screening, brief intervention, and referral to treatment. This is at least as hepatologists and gastroenterologists and physicians we should and can do in our practices. Doesn't take more than 5 minutes or so. Let me focus on the first part is a brief audit C score, which is 3 questions. The first question is, how often you drink alcohol? And if the answer is never, you stop there. But if there is some bit of alcohol going on, the next question comes, how many drinks on a typical day? Again, it is scored self-reported by the patient from 0 to 4. And then the third question comes, how many times? 4 or more drinks per occasion, and that also is reported from 0 to 4. From a total score of 12, anything 2 or higher in a female, 3 or higher in a male is suspected of at-risk alcohol use. And that is the population. Once you identify, you need to focus on what is called motivational interviewing or brief intervention, which takes about 5 minutes. And you are basically educating the patient about harms of alcohol use in a very non-judgmental, empathetic fashion, and then trying to get the patient involved and get their feedback onto self-realistic goals of what they want to do with their ongoing alcohol use, which can be harmful to their health. And there is a link down there called SBIRT Interview Alcohol Screening. I would, after finishing the slide before the panel, I might take that if there is time. It's about 10-minute interview. I think it shows you how to conduct an interview and how to address alcohol use with a patient by a physician. And the interview is conducting is a nurse practitioner. I specifically use nurse practitioner because that means if nurse practitioner can do it, we as physicians and gastroenterologists, hepatologists can do it. So let's go back to the case first, and I'll come to that video later on. So this alcohol use of this patient in the last 2 years increased. So remember, she was met ALD. Now in the last 2 years, her alcohol use in disease state has transitioned to more ALD. And now she presented with cirrhosis. Okay, she has thrombocytopenia, she has anemia, she has synthetic function is abnormal, her liver ultrasound is classical nodular cirrhosis, and she also has perisplenic collaterals without a focal lesion. The question 3 is, does this patient have clinically significant portal hypertension? That's a genuine question because CHBH is an important component in the natural history of cirrhosis patients, as we all know, and it can increase the risk of decompensation. And this is where comes the role of transient elastography. In this patient, I think she had imaging features of CSPH. She had collateral, so I don't think there is any doubt about that. But if you don't have those, then the fibroscan or transient elastography can be very useful. At a liver stiffness below 15, you can rule out the diagnosis. At a liver stiffness of above 25, can you rule in the diagnosis of CSPH. And in between 15 and 25, you can take the help of platelets or splenic stiffness can help you in making that determination. So the next question comes, which medication you would use for controlling her alcohol use? Because you can put on beta blockers, you can treat her cirrhosis, you can follow the patient in the liver clinic for cirrhosis management. But I think the downside question is how to prevent alcohol use so they can prevent decompensation and improve her survival. I'll not go into the details about the FDA-approved therapies. I think Dr. Vinod Dixit did discuss about most of these medications, so I'll spare some time here and go over to some of the repurposed medications. I'll spend some time there because the acamprosate and naltrexone, which are FDA-approved therapies, which can be used in liver disease patients, are not always effective. The number to treat is about 8 to 10 to get one patient abstain from alcohol. So really need new therapies for alcohol use disorder. And in the upper row, you see the non-FDA approved medications like baclofen, gabapentin, Chantix or varenicline, topiramate, Zofran or ondansetron. Those are the ones which are non-FDA approved and very frequently used. Some of them are even endorsed, like baclofen is endorsed by ASLD and ACG guidelines. Gabapentin is endorsed by American Psychiatry Association guidelines. But I want to focus also on some of the dual targets here. What I mean by dual targets is targets which are not only helping the liver disease, but also helping the alcohol use disorder. And the targets are listed over here. I'll spend a couple of them over here in the next few slides. This is from our center. Lactobacillus GG, which is a dual target, and was tried in about 46 patients with moderate alcohol-associated hepatitis. What you see in this graph or the figure, there is a decrease in MELD score in MAH patients after 1 month of treatment. But what was most striking, at 6 months, the alcohol use significantly came down. So LGG can be a dual target that it improves the liver disease, but also alcohol use disorder. This is another interesting molecule which we are trying to study in our lab and in our center, which is N3-PUFA, or polyunsaturated fatty acids. And these are the results of a 12-week trial of N3-PUFA supplementation in patients with alcohol use disorder. Remember, these are not the patients with liver disease. These are patients with alcohol use disorder studied at NIH, and this kind of study can only happen at NIH. They had a CSF examination before N3-PUFA was given, and a second CSF examination at 12 weeks after the PUFA therapy was completed. And I'll show you the results here. And the results showed that the components of the PUFA, which is EPA, and the other component of the PUFA increased in patients who received PUFA supplementation, and this was a placebo-controlled trial. But in the placebo population, they remained unchanged. So there was no change in that concentration of the components of PUFA. The middle figure shows you how at the end of 12 weeks, the heavy drinking days came down in patients who were given PUFA but not in placebo. And on the right-hand side, you see their AST, ALT levels came down. So proof of concept that it's a dual target. It helps control the alcohol use and it also helps control the liver disease. And trying to study in a clinical trial N3-PUFA in patients with alcohol use disorder. So stay tuned. Another dual target is a GLP-1, which I think we heard a lot about it, which is glucagon-like polypeptide 1 agonist. And these are on the left-hand side, you see the effect in NASH patients or MASH patients, both non-cirrhotic and cirrhotic population. There is benefit. And now, 2 weeks ago, we know that GLP-1 is an approved indication for MASH. But I want to focus here on 3 randomized controlled trials, and this paper was put together by one of our fellow, Hannah Blaney. It is expected this month in Alcohol. And these 3 randomized controlled trials are showing a very heterogeneous benefit of GLP-1. So it's a potential target, but it's not the best target. For example, one trial studied exenatide, the other trial studied dulaglutide, and the third trial studied semaglutide. And 2 of these trials were positive, 1 trial was negative. And the sample size is very small, as you can see, and about 62 patients, 76 patients, and 24 patients receiving the medication. What about FGF21? No human data, but there is very interesting animal data, which I'm not showing here, but very interesting animal data to show not only endogenous FGF21, but also exogenously administered FGF21 has an impact through central mechanism and decreased alcohol use in these patients. And this is the data here shown on the left-hand side is the non-cirrhotic population, MASH, showing benefit. And on the right-hand side, cirrhotic population, MASH, showing the benefit of FGF21 in terms of improving FDA-approved endpoints of improving fibrosis without worsening inflammation. So let's come back to the case now. She was discharged on non-selective beta blocker, and she was discharged on a camprosate and was referred for counseling and therapy sessions. Now she comes back to the same program 9 months later, now comes with jaundice and weakness. Labs, she's clearly alcohol-associated hepatitis. Now, severe alcohol-associated hepatitis, she continues to have cirrhosis. In between, she got to 2 other hospitals, stayed sober for 3 months, but then in between that 3 months and 9-month period, had 2 admissions where underwent TIPS procedure 1 time for ascites. Infection workup was negative. She was started on prednisolone. Lille score was 0.36, and she was treated for full 4 weeks and continued on a camprosate. Case continues. After 6 weeks of sobriety, so she stays again 6 weeks sober, relapse to alcohol use. So this is what we as physicians need to recognize. More than a behavior, this is a disease. So they are struggling with 2 diseases. It's a dual pathology more than the liver disease. And this you can see, in spite of going to deathbed 2-3 times, she's drinking again. So she was hospitalized 3 months later with recurrent severe AH with grade 2 encephalopathy, anemic, platelet count went down further, bilirubin went up further, so it's just deteriorating everything. And now she's developing pneumonia and she's in ICU. So what would you do to improve her liver disease and survival at this stage? Could transplant be an option? And here is the score. I just put it from one of my friend, Brian Lee, who's put together the SALT score, which you may have heard about. If you look at the score points here, the number of drinks, prior failed rehabilitation attempts, history of prior alcohol-related legal issue, and non-THC illicit substance abuse, she's scoring on everything. She's the highest risk patient. So clearly not a candidate for transplant, at least in our center. In most centers in America, she will not be a candidate for transplant at this point of time. So what do you do for these patients? And this is the algorithm which we all follow in patients with severe alcohol-associated hepatitis, patients who are ineligible for steroids or ineligible for medical therapy, or who are ineligible for transplant after failing steroid therapy. Either you enroll them in clinical trials or you discuss goals of care. Those are the only 2 options. Is there another liver target therapy available? Currently, no, but there are some which are ongoing. Most of them are following with negative trials, but there are some positivity here. Interleukin-22, DOR928, maybe fecal matter transplantation, and some of the silencing gene approach therapies for alcohol-associated liver disease. There are several therapeutic targets which are being tried here, targeting gut-liver axis, inflammation, regeneration. I'm not going to go over the details here. The number keeps on growing, but as of today, we don't have one which is FDA approved. Coming back to the case, she was transferred to ICU with pneumonia, worsening mentation, respiratory failure from ARDS, intubated, required pressures, CRRT, supported with treatment, not eligible for transplant, worsened, cliff ACLF score of 72, family decided comfort care measures, passed away 48 hours later. Bad outcome. And this is the slide I want to show you, the outcome of this patient over the period of 1 year from the time we started seeing her till she died with a recurrent AH, ACLF, pneumonia, and death. Could this have been prevented even after the onset of cirrhosis? The answer is yes. And this is a third preventable non-communicable disease. So alcohol-associated liver disease is totally preventable. Third preventable non-communicable disease at any spectrum, whether it is an early stage of liver disease, a more compensated to decompensated liver disease with cirrhosis like our patient, or alcohol-associated hepatitis which happened in our patient. One option and the one outcome could be what happened to this patient, which is hospitalizations and mortality. And the other outcome, she could recover and recompensate. And the only thing which will go one way or the other is how you control the alcohol use as a shared decision and a shared pathway making between the physician and the patient. And that's where I think the field has to go in terms of developing new therapies and also clinical practice. But in real world, it is rarely treated, alcohol use. And this is now I'm showing you the real world experience, why that is. And I'll stop this slide here. Maybe I should come back to this slide after showing you that video, is that what are the barriers and how you can overcome those barriers. I think at a clinician level, we need to develop strategies so that we can overcome our discomfort in handling alcohol use in these patients. I mean, better training, maybe, if I can use the word. And some of that may be linked to the patient level barriers, how we talk to the patient and patient perceiving stigma attached to that alcohol associated liver disease. And then the system level barriers, which is how much time we have to see patients. And we are seeing patients in one building, and addiction people are seeing patients in another building, and patient doesn't want to go to that addiction center. So those are some of the other barriers. So I don't want to go into those details, but the video, if I have time to show you, will go over some of these issues and how to overcome some of these. And what about treating alcohol use disorder and liver disease in research? Look at the outside liver transplant setting, 100,000 patients close to. Pharmacological therapy is only 300 patients. So ever since now, such a common liver disease, only 300 patients are enrolled in pharmacotherapy development for alcohol-associated liver disease for AUD treatment. Clearly, there is an unmet need, despite observational data showing there is a benefit. What about transplant recipients is even worse. There is no study investigating pharmacotherapy in liver transplant recipients. So it's clear unmet need for developing new therapies. And that's what Patrick is here. He's part of that consortium. Under the consortium in the US, 6 sites, we will investigate a double-blind, placebo-controlled liver target, which is interleukin-22 against prednisone. And these are all steroid-eligible patients. And right before discharge, so we're not waiting for these patients to go 1 month, 2 months, or 3 months. Right before discharge of that hospitalization, these patients will be open-label randomized to either motivational interviewing, motivational therapy, and acamprosate versus SPURT, which is the standard of care, screen, brief intervention, referral to treatment. And then we investigate them for liver outcomes, alcohol outcomes, and some of the metabolic outcomes, patient-reported outcomes at 1 year. So this is the next 3 or 4 years. The trial, I think, will set how we might be able to handle these patients in clinical practice if the trial comes positive, which we are very hopeful. And I want to acknowledge some of the funding and some of the collaborators we have before I take questions with the panel, and then maybe if we have time, go over that video over there. So I don't know whether you want me to go over the video first or take the panel questions, or Ashwini, what do you want me to do? Okay. Yeah. How I do it. Oh. Okay. How I do it. Somebody will have to help me here. Maybe now. No internet? No internet? Okay, so we cannot play it? Okay, well, we got the answer. So we might wait. If the internet comes, we might. So, okay, so what? So we should not play the video? No internet? Okay, no problem. Well, that was a good interview for us to see how we should address patients with alcohol use disorder, and I think, but that's okay. So before we close, I have some questions for the panel. Maybe something which I did not cover. So maybe I can take the first one with Dr. Amit Goel. Okay. So Amit, your question is, how would you approach assessment of fibrosis risk, like the using the serum markers and the radiological markers in a patient who has liver disease but is also drinking alcohol at the same time, actively using alcohol?
So yeah, it's okay. So practically we are relying more on like fibroscan, transient elastography, but we know that the value we have to take higher as compared to those established for viral hepatitis or simply fatty liver disease because of the underlying inflammation in particularly in context of alcoholic hepatitis. So that is one. Also we can take help of cytokeratin marker, 18 serum marker, and platelet count, absolute value, APRI and FIF4. So we are taking combination of all possible things. Biopsy we are hardly doing for just to assess fibrosis until unless we are planning for steroid.
Yeah. For the sake of time, let me summarize. You answered everything. Just to summarize, what Amit is trying to tell us, that in a patient with active alcohol use, should be cognizant that the underlying inflammation, not the alcohol use, just the inflammation, and the markers we use in practice for looking at the stiffness value with a little bit pinch of salt. If your AST level is above 50 or bilirubin is higher. So in that setting, if the patient, as say, for example, comes to you with steatosis and you want to investigate with a fibroscan, but the patient is drinking, if your AST level is above 50 to 60 and bilirubin is higher or one of the two, then you may want to wait for 2 weeks, reassess the patient after he abstains, and then examine that patient. CK18 will tell you whether there is alcoholic hepatitis or not, or a walking AH, with the non-jaundiced AH. CK18 might help you there, or it may not help you determining which patient has the confounding. The AST value will help. Anyhow, Dr. Huh? You can copy this link. Okay, sure. इसका लिंक इसका URL डालो. Yeah. Want to copy? You want to copy here?
Control D करो. Control D.
We need to congratulate the team for their hard work. Yes,
So you need to treat us with a drink now.
that's right. But I won't drink. You know that. Copy. Copy. Oh, there it is. So we'll see the video first.
वीडियो को अपनी तरह कम करते हैं तो चलेगा नहीं
यहाँ से वो कर लेना।
So in this scenario, I'm a nurse practitioner in a primary care clinic, and I'm seeing a gentleman, Mr. Powell. He's a 37-year-old African-American male, and he comes in with his primary concern of a sprained ankle. And prior to the appointment, he completed the audit questionnaire, and so I'm aware of his drinking patterns and behaviors. So, Mr. Powell, thank you for coming in today, and thank you for filling out this lengthy questionnaire. It really helps me kind of guide the process here.
You got it.
From the questionnaire, it sounds like you drink about 4 to 5 times a week, and about 4 drinks a sitting, and you've had some blackouts in the past, and possibly some other negative health consequences because of the alcohol.
Yeah, I think that's true. Yeah.
Okay. So do you mind if we talk a little bit about your drinking, what you like about it, what's fun for you when you drink?
Yeah, but I'm not an alcoholic.
Oh, I'm sorry if I gave you that impression, Mr. Powell. That's not what I intended. We just ask all our patients these questions, kind of a routine patient questionnaire. So just to kind of assess where they are in their health patterns.
Oh, okay.
So it has, and I'm sorry again if I gave you that impression.
Sure, go ahead.
So tell me again the things that you like about drinking. What's fun?
After work, I work in a machine shop. I like to go home, take a shower, have a beer, you know.
Okay. So it kind of relaxes you.
Oh, yeah.
And are there any other drinks that you like to drink other than beer?
Yeah, sometimes I go out with my fellas on weekends at a social club. We play darts and pool, and I'm like, sometimes about 4 beers, and sometimes we do shots of tequila.
Okay. So sometimes when people are out with their friends and they find themselves drinking more, has that ever happened to you?
Oh yeah, when we get together, it's a hoot. It's a hoot.
So about how many times, like, is 4 drinks, 5 drinks? Could you?
I'd say somewhere between 4. Sometimes I don't know. Like 2 nights ago, I think it could have been 6. I'm a little fuzzy on that. Yeah.
Okay. And so you're here today because you fell and you sprained your ankle.
Yeah.
Right. And can you tell me the kind of what was going on?
Oh, we were playing
darts.
darts. I almost won until I came in second.
Oh.
Yeah.
How many times do you win?
I won? Oh, God. I can't even count. At least 20. I'm pretty good.
It sounds like you're pretty good.
Yeah.
I wouldn't want to take you on. Well, you're playing darts, and how much, you said you kind of have a few when you're with your friends. So
Yeah.
about how much do you think you were drinking before you sprained your ankle?
Yeah, that night was pretty wild. It could have been somewhere between 4 and 6 beers. Yeah.
Right.
Yeah.
So do you think the alcohol may have led to the ankle sprain?
Well, actually, yeah, come to think of it, could have been. I live real close, so I was walking home. I didn't drive or nothing.
Okay.
I was walking home, and it's the usual path I take. It's a short distance, but I went off a curb, and bam, wow, that hurt.
Okay. So how did you get home?
Well, one of my other friends was leaving, and he saw me.
Okay.
Yeah, so they put me in the car and drove me home.
Okay.
Yeah.
So besides spraining your ankle, are there any other kind of maybe negative things that happen when you
my
drink?
girlfriend, she doesn't like it sometimes. I think it's kind of silly, but yeah, she doesn't like it when I tie them on. Yeah.
Okay.
She has problems with that. But she's a good lady. She scolds me a lot.
Yeah.
Yeah.
What is
Good
it?
lady.
Yeah. So when she scolds you, how do you feel?
Oh, sometimes it's tail between my legs. She can really crush it. And sometimes it's just we laugh about it,
Okay.
but she's still needling me.
All right.
Yeah.
Well, it sounds kind of like that's a relationship strain sometimes.
Oh yeah, it can. I think. Well, she don't like it.
Yeah.
How can you better say it? Yeah, that's a stressor.
Okay. So you've had some consequences related to your alcohol use.
I have.
So would it be okay if I give you some feedback about your drinking?
Sure, go right ahead.
All right. Well,
I figure that's where you're going.
Well, you're right. And so from what you've talked to me about, it sounds that you drink about maybe 16 drinks a week, about 4 or 5 drinks a sitting. Is that correct?
Yeah, that's true.
Okay.
That's true.
Well, so this goes over the limits for males and females, and the limits for males are about 14 drinks a week. And when it gets to be more than that, it can lead to negative health consequences like high blood pressure, heart disease, diabetes. What do you think about that?
Wow. It sounds like I should think about cutting back. That's what it sounds like.
Okay. So on a scale of 1 to 10, 1 being not ready to quit at all, you're going to walk out that door and have another drink, versus 10, how ready are you to make that change, with 1 being not ready to change at all and 10 being I'm ready to change as soon as I walk out this door?
Yeah, 5 or 6.
Okay. Well, that's great. I mean, 5 or 6, that's 50 to 60% ready to change. So what makes you respond that way versus a 1 or 2?
Well, I sprained my ankle. My girl, she doesn't like it. Well, I'm going to miss work. I'm not going to get paid for the day and tomorrow. So there's a couple right there.
Okay. So what do you think, what kind of steps could you do to reduce your alcohol use?
You said I'd do like 14 a week and 4 a night. Well, boy, it went down to 3. That'd be less. I think I could do that, and just 4 would be my top.
Okay.
Yeah.
You know, sometimes when I have patients making a change, whether it's dietary change or exercise or drinking, I have them write things down in a journal. Like, for example, with alcohol, how many drinks they've had during the course of the day. How do you feel about doing something like that?
Wait, I do it?
Right.
Every day. What would I do?
Well, you could write it down, either the number of drinks that you've had, and I could give.
So you saw this interview. Maybe I can ask the last question to Dr. Setia. So if you could summarize for everybody and Dr. Setia about the interview when that provider was addressing the alcohol use with the patient.
Well, thank you very much. I think first, before I summarize, there is a little comment on the interview. See, setup in India is very different. We are short of time. We do not have nurse practitioners. And therefore, what we need to do is, and what personally in few patients that I see, that we put them in what is, I would like to call as a therapeutic alliance. That I will tell them that, you know, they expect you to be judgmental. And that's why they're very shy in admitting things, right? How much alcohol. So it's very difficult to take the exact amount of alcohol, what kind of drinking, etc., etc. So you got to put them at ease. And I would like to say that, listen, I'm here to help you. I'm not being judgmental on whether you drink socially or whatever. So that is what my approach would be. Most of other points have been covered earlier by Dr. Dikshit and you too. And therefore, I would not like to waste my time on that. All I wanted to say was that the setup here is very, very different. And one thing I think I would like to bring out is, in all these alcohol use disorders, what gets very easily overlooked is the nutritional deficiencies and nutritional counseling thereafter. We all know about what pharmacotherapy we can do, or at what time the psychologist needs to be involved, etc. And some, whether it is a group therapy or single Alcohol Anonymous, etc., etc. And there are challenges. Challenges are that, there is a stigma associated. We do not have very many options other than those trial you mentioned as far as the drugs are concerned. So these are challenges. We have to work around that. Yeah. Thank you.
No, I think you covered it all. I mean, not only India, the time limit to see patients is even in America. We are pressed for time and see patients, and the next patient is waiting. So that barrier is always there, and that's where it's not just the clinician or the patient, but the system as a whole. It takes about 5 to 10 minutes of your time to get this done in the right way, and the right way was shown in that interview. But I want to thank everybody for your patient listening, and I hope this session was helpful for you. Those of you who take, yes, you have a question?
Thank you. I generally encourage my patients. I have numbers of Alcoholic Anonymous written, and in India also there are more than 2,500 centers all over the country.
Yeah.
And there are several hospitals, schools, colleges, churches, which offer space for these meetings. So as a gastroenterologist, I agree we don't have time to do it for our patients, but we should keep some ready numbers, some ready sponsors. There are AA sponsors who are there, who are more than happy to visit the patient's place and become a sponsor for that patient and encourage them to do that at least. So that's one thing I think we could do because we have this in our country.
Yeah, but to get there, we have to identify these high-risk people. And one of the messages of the session today, that when this patient, like this patient, came for an ankle sprain after he fell down. And this high-risk alcohol use recognition could have escaped if that nurse practitioner has not done that interview and self-reported, spent those 10 minutes with the patient. This is exactly what happened to the patient we had, and she went into cirrhosis. So unless you identify that high-risk alcohol use, then comes the role of referring for treatment and all. Thank you very much.
So, thank you, sir. Thanking our panelists and chairpersons. Moving on to next session, which is also a case-based panel discussion on drug-induced liver injury-related ACLF. And the panelists for this discussion are Dr. Mukul Rastogi, Dr. Abhinav Verma, Dr. Sanjay Khanna, Dr. Deepak Lahoti, Dr. Rajat Kalra. And the chairpersons are Dr. Gaurav Bachav, Dr. Rajiv Shandil, Dr. Indranil Saha, Dr. Hari Kumar Nayyar, and Dr. Shankar B. Khalko. And the speaker for this discussion is Dr. Kaushal Madan.
With the permission of the chair, can we start?
Yeah, please go ahead.
Yeah, thank you. So good evening, everyone. So this is a case-based panel discussion on drug-induced ACLF. We have got only 20 minutes, 5 panelists, 5 chairpersons, and the entire audience. So, just before I present and thanks to Dr. Arora and Praveen and Ashish for giving me this opportunity. So before I go on to the case, just a brief background and certain brushing of facts. So these are the types of drug-induced liver injury we usually see. The direct or intrinsic, which is usually reproducible, dose-dependent. Beyond a threshold, you know that the patient will develop DILI. Example is acetaminophen. The second is idiosyncratic, which is much less common, and it is unpredictable. The most common example is amoxiclavulanate. And third is indirect or intermediary. The most common example is checkpoint inhibitor-induced DILI. So a number of molecular mechanisms which lead to this: direct hepatotoxicity, mitochondrial injury, reactive oxygen species, inflammation, leading to cell death, apoptosis, necrosis, and ultimately fibrosis. But I think the most important myth which needs to be busted is that most people think that once a patient has CLD, that person is always predisposed to DILI, but that is not true. Just to give you an example, there is a differential predisposition to DILI in different CLDs. For example, this study 50 explant livers from CLD compared to 21 normal livers, and look at the differential expression of the enzymes which get affected. For example, NADPH levels remain normal. The other CYP450 enzymes, some of them will only be reduced in cholestatic liver diseases, others will only be reduced in hepatocellular diseases. So it depends on the type of toxin, type of liver disease, whether the patient will develop DILI or not. But it is a common pathway there of once the patient develops DILI in CLD, the mortality is universally high, and a number of studies, including the Spanish DILI, the US DILI network, and Indian DILI network, has shown that once the patient has CLD, the mortality is higher than non-CLD patients when they develop DILI. So with that, we come to the first, the only case, 63-year-old male, non-alcoholic, obese gentleman, diabetic for 18 years, mostly controlled, presented with, he had been having PO for 1 month duration for which he was investigated with a PET CT which revealed multiple necrotic lymph nodes. FNAC from them revealed granulomatous inflammation, and had been started on 4-drug ATT almost 2 to 3 weeks back. Came to us now with nausea, vomiting of 10 days duration and altered sensorium of 3 days duration. These were the labs: hemoglobin of 9, 21,000 is the TLC, INR 1.9, creatinine 1.7, bilirubin of 9, ammonia 130. These were the liver enzymes. All viral markers negative. Ultrasound revealed hepatomegaly, fatty liver, mild to moderate ascites, bilateral pleural effusion. I've already talked about the FNAC report. So this was the final diagnosis: disseminated tuberculosis with ATT-induced DILI with ACLF. I know some of the purists might want to call it ALF. Why not ALF? But that is not the point of discussion today. With ascites, HE, and AKI. Possibly underlying MACLD with acute insult being drug-induced liver injury. According to ARC grading score, it was grade 2. So let me bring my panelists into it. Dr. Rajat and Dr. Sanjay, you can take up these issues. How do you decide on the regimen of ATT among patients with cirrhosis? Do you use a different regimen in your clinical practice?
So the regimen, basically we have to give ATT, and basically it's going to depend on the child score of the patient, what we follow. So if it's child A, we need to give only 2 hepatotoxic drugs, which we give in our patients, and the duration remains almost 6 to 9 months. We can follow HRE regimen for the entire 9 months, or we can give 2 HRE for 2 months and then follow with HR for the rest of the period. And for child B, it's got to be only 1 hepatotoxic drug out of the 2, rifampicin or INH, and the duration needs to increase to 9-12 months along with another drug from the second line, aminoglycoside or along with ethambutol aminoglycoside. And for child C, we need to avoid both the hepatotoxic drugs, and the duration has to increase to 18 to 24 months.
Right. Any difference of opinion, Dr. Rajat? Similar. So most of us would follow this. This is what is given in guidelines, and people follow this also, except that some people would want to give HREZ in child's A cirrhosis. For example, me, in a patient who is well compensated and requires ATT, I give all 4 drugs in child's A cirrhosis. And there is data, this is again data published by Praveen from Ganga Hospital, 67 patients, 7 of them were CTP-A, 44 CTP-B. These were the regimens they used. CTP-A were given all 4 drugs. Other regimens were RHEO, HEO, or REO, O being ofloxacin. And they found that ATT-induced hepatitis developed equally in all groups, and none of the patients who were given RHEZ developed ATT-induced hepatitis, provided they were compensated patients. On the contrary, this is a data from PGI Chandigarh of 27 patients with TB and cirrhosis, HREZ given in 5. All of them developed ATT-induced hepatitis, but many of them were decompensated to begin with when they were started on this regimen. So child's A cirrhosis, if you monitor closely, you can get away with HREZ, but still the recommendation says that avoid pyrazinamide. So I think this is another important question which keeps playing on our mind, and people do keep discussing it. Which is a more hepatotoxic drug? Is it rifampicin or INH? Different school of thoughts. For example, we trained from AIMS, we think that rifampicin is safer. People trained from GV Pant and PGI Chandigarh, they are more happy using INH. So which is safer? This particular study, which looked at the various prophylactic regimens where these drugs are used alone in non-cirrhotic patients compared these regimens. So this one comparing rifampicin versus INH showed that rifampicin was found to be less hepatotoxic as compared to INH. This is talking about data, and what I told about earlier was just experience. So Dr. Deepak, coming back to the case of DILI-induced ACLF, how often do you see drug-induced ACLF in your practice? And what are the usual incriminating agents?
Dr. Madan, we see a lot of patients with drug-induced liver injury in OPD as well as IPD, but we see ATT-induced liver injury. We see patients who have complementary and alternative medicines and even food supplements probably responsible for liver injury. But we are discussing ACLF today, and most of our patients who come with the evidence of liver injury do not satisfy the strict definition of we use a partial definition.
Right. I think we keep on incriminating a lot of herbal medications and complementary and alternative medications, but sometimes it becomes very difficult to pinpoint or say that, yes, this is the cause, and I agree with you. So these are a few studies from our setup. So the first study is a single center study, which showed that about 5.2% of all ACLF were DILI. The other is a multi-center inasal data, again using a partial definition, 4.5% being DILI. And this one is from the Asia Pacific region by Harsha Devar Bhavi. The ARC group, about 10.5 to 11% patients were DILI-induced ACLF. And yes, in Asia, the most common reason for DILI is drug-induced DILI ACLF is anti-tubercular therapy, followed by anti-epileptics and herbal medications or complementary alternative medications. So this I have picked up from the criteria used, which Dr. Harshad used in his particular study, how they diagnosed DILI-induced ACLF in a patient who has pre-existing liver disease with an elevation of transaminases that was at least 2 to 3 times the baseline, or bilirubin levels more than 2 times baseline, also fulfilling the criteria for the APASL criteria for ACLF. This is how they diagnosed DILI-induced ACLF in their patients. So I think this question is to the audience. Do you use any score in your routine clinical practice? I'm not talking about research. Any score in your routine clinical practice for making a diagnosis of DILI? Patient comes to you in OPD, you are suspecting that he took a herbal medication 10 days back. Do you use any score? Yes. How many for yes? Only one. So I think rest all I presume is no. So, and I agree with you, it is a difficult job, although this is once you read it, you find that it is a very easy thing to use, but once you start using it, you realize there are so many variables in this. These 7 variables, I am not talking about these 7 variables. How you score these 7 variables will take a lot of your time in the clinic, and then you are able to make a diagnosis of exclusion, unlikely, possible, probable, or highly probable diagnosis of DILI. So that is why we are not able to use it, and many a times we just presume that possibly patient took this herbal medication or Ayurvedic medication and was the reason for his raised liver enzymes. And like this, there have been other scores also, and recently there is a score called RECAM, which is the electronic version of RUCAM, a digital version of RUCAM, which might be easier to use. So coming to the next issue, since we are talking about ACLF, so you've seen the patient right now, he's grade 2 ACLF, Dr. Abhinav. Would you refer this patient for transplant or continue with conservative management? Any criteria which helps you to decide regarding early referral, or any point in a DILI-induced ACLF which helps you to decide?
Yeah, so data you showed that DILI-induced ACLF carries poor prognosis. That is one point to consider. The other thing is this patient has been long-standing diabetic with low platelet count and high iron or high creatinine. Bilirubin is high. So he is definitely on wait list for transplantation. But if encephalopathy is just grade 1 to 2, then we may try conservative treatment, monitoring him day 0, day 4, day 7. If he's improving, then he's off the list. But if it is encephalopathy grade 3 and 4, then immediately we have to go for transplantation.
Right. Any other panelists want to add to this or specify?
So if you see the ARC score, Purcell ARC score, this patient fits in between 8 to 10. So 8 to 10 score is having almost 45% chances of mortality in such cases. So I think over a period of golden window, 7 days, we should advise for transplant for this patient, because even if you stop ATT, it is very difficult to save him. Enzymes, everything
I
is
think
high.
the most important point which the panelists have made is that a DILI-induced ACLF as compared to a non-DILI-induced ACLF has a higher mortality and less likely to improve on conservative management. So early referral for transplant should be done in these patients. So this was the one of the largest studies from Asia Pacific region where the most common agents were CAMs and ATT induced, and they showed that the 90-day mortality was almost 46% versus 38% in non-DILI. They also showed that whether it was ATT or CAM induced, the mortality was similarly higher as compared to non-DILI ACLF. So these patients should be referred for transplant early. They looked at several criteria and they found that independently lactates and total bilirubin at day 7 predicted poor survival. So this is what happened to the case. This was around day 6 when his INR remained intact. I think he was given FFPs. Patient was admitted under physicians who tend to overtreat coagulopathy, and his creatinine was still 1.6. He was producing good amount of urine, but bilirubin had risen to 17. The albumin had gone down to 3. Patient's coma had deepened and he was put on ventilatory support, but still there were no inotropes. So Dr. Sanjay, is this the right time to send for transplant, or would you like to do something else? A trial of plasmapheresis perhaps?
I think we've already discussed that this patient actually now, after such a long time with worsening liver functions and other body parameters, requires a transplant. He should ideally be offered a transplant. However, if the patient is not willing or is not a candidate, then possibly other therapies, especially trying to preserve the other organ systems, nutritional support needs to be done. And trial of plasmapheresis in the cases of DILI related ACLF, though we don't have too much of data on this, but certainly if we don't have anything else to offer, we can offer it. Out here, I'd like to mention one study from Dr. Rela's group actually. It was a retrospective analysis of around 10 patients where they did not in ACLF, only severe DILI, where bilirubin was more than 15, and they offered plasmapheresis of around 2 to 3 times per patient, and they had a decent response out there. So
And-
out this patient, ideally transplant and not ideally plasmapheresis.
Right. So since we just want to discuss it, this is a large meta-analysis which showed that with plasmapheresis in ACLF, there is a reduced mortality at 30-day and 90-day, but most of the maximum benefit was achieved in HBV-related or alcoholic-related ACLF, and very poor data, or I would say lack of data in DILI-induced ACLF on impact of plasmapheresis in terms of survival. So I think people talk a lot. I know. Let's for a second assume that this was not ATT-induced hepatitis, some other drug-induced hepatitis. Dr. Rajat, is there a role of steroids for drug-induced ACLF? Once the patient develops ACLF liver failure, would you risk giving steroids or refer for transplant straight away?
Role of steroids in drug-induced ACLF is controversial. If the patient has drug-induced AIH, so is steroids can be tried, but it will be very risky because there is a high risk of infection in these patients.
Right. So I think there are very specific indications. Drug-induced AIH are the ones in which you can still go ahead even after development of liver failure and give them a style of steroids where you wait for 1 or 2 weeks maximum, and if the patient is not improving, then you refer those patients for transplant. However, in DILI-induced ACLF, there were this was a meta-analysis. There were 2 studies in which none of these studies showed survival benefit in DILI-induced ACLF with or ALF with steroids. Like you said, the specific indications are drug-induced AIH, and now with a rampant use of immune checkpoint inhibitors, immune checkpoint-induced DILI, which is like autoimmune hepatitis, but not exactly autoimmune hepatitis, but has a good response. Almost 80% patient will respond to steroids or other immunosuppressants. So I think since we've all agreed that transplant is the treatment of choice for this patient, so the other issue is managing these patients post-transplant. Patient has active tuberculosis and you are transplanting this patient. So would you be transplanting in presence of active TB, transplant and treat later? And how would you manage it?
I think we should go for transplant first. We have to make the patient survive and then treat the tuberculosis. So when to start ATT? ATT should be started when the liver functions become normalized, because lot of things happening after transplant. There are lot of hemodynamic changes, a lot of rejections, or there is technical problems like Doppler studies for ischemia, or lot of factors, sepsis. So when a patient comes out with all these factors, then I think once is LFT is stabilized, then start ATT. And most
would
of
you
the
say
time,
a week or 10 days or 15 days?
maybe 1 or 2 weeks
maximum.
Maximum.
But a patient has active TB and that also has to be kept in mind.
Yes.
Right. Before you come to the regimen, let me ask the audience, for treating TB in post-liver transplant setting, I don't know how many of you are treating patients in the post-transplant setting. What is your strategy of choice? Standard regimen, RHEZ, or a rifampicin-free regimen, or use rifabutin in place of rifampicin? Show of hands for A, B, or C. Many for A. Full dose, rifampicin free, few for rifampicin free.
So the clinical picture of tuberculosis post-transplant is quite difficult than the immunocompetent. Most of the cases are extrapulmonary TB or disseminated tuberculosis. So these type of patients should be treated adequately, and I think the standard regimen should be followed, where rifampicin should be there because it is the most effective ATT and it is having the highest sterilizing activity. So all the regimen should contain 4 drugs, and pyrazinamide is the most hepatotoxic. So it's better to avoid pyrazinamide and continue with rifampicin, Isonex, ethambutol, and definitely quinolones. So if you give these 4 drugs for 2 months and standard 4 months for H and R, that is for normal. But those who are having disseminated or extrapulmonary tuberculosis like joint involvement, bone, or CNS, in such cases, even 9 months is required for the treatment.
Right. So the reason for not using rifampicin, or the issue, the contention is because rifampicin is an enzyme inducer, and the CYP3A4 potent inducer, and all these immunosuppressants are substrates for this enzyme, and you have to increase the dose 3 to 5 fold to maintain adequate drug levels.
Yeah, I agree. I agree. Rejections are more with rifampicin, but you have to give rifampicin in our post-transplant patient. Otherwise, this tuberculosis become disseminated or multi-drug resistant.
Right. So again, there's a difference of opinion. Most transplant centers would want to use rifampicin-free regimen in India. There are a few like Dr. Mukul. I had a word with Dharmesh. They also use rifampicin freely in these patients. You were
We have to
making
keep
a point.
in mind that rifampicin may interfere with bilirubin excision, and there may be benign bilirubin rise. So we have to be careful.
Right.
That is in general population also.
Right. So regarding results of patients transplanted with active TB, this is data from ATT-induced ALF and who were transplanted, that if you transplant, yes, their survival is lower than patients who do not have tuberculosis, but still you are able to achieve significant survival ranging from 70 to 80% if they are transplanted well in time. So I think that with that we come to the end. These are the take-home messages. DILI-induced ACLF may be responsible for up to 10% of all ACLF from India and Asia, most common precipitants being ATT and CAMS. While the predisposition among patients with cirrhosis may vary to develop a DILI, their outcomes are definitely inferior to non-DILI ACLF. In view of higher mortality in these patients, early liver transplant should be advocated in all these patients. Managing TB in a decompensated cirrhotic is challenging, especially with hepatotoxicity. With the first line agents, you have to either not give any hepatotoxic agent or use 1 or 2 of them. ATT-induced ACLF or ALF are best treated post-transplant. I mean in terms of their TB management, and the challenges are the use of regimens which contain or do not contain rifampicin. The duration is longer, there is a higher risk of graft failure and therefore higher mortality in these patients. Thank you for a patient hearing.
Before we end, may I have a question to panelist, August Khan. Why don't you keep streptomycin as a one of the pharmacological agent to treat when you suspected disseminated tuberculosis and probably encephalopathy, who are masquerading as an encephalopathy of hepatic origin. Streptomycin is a good choice. It can cross blood-brain barrier.
So most of the post-transplant patient are having renal dysfunction. So if you use aminoglycosides in renal patients, because tacrolimus is also causing.
I'm talking about before transplant.
Yes, they can be used.
Yeah, before transplant
So
we can use.
Streptomycin we want to avoid because that has to be given intramuscularly, and many of these patients have coagulopathy. But yes, amikacin can be used, which can be given IV.
You know, there is another anti-tubercular agent. It's sold with the trade name Terracox. That's terazolidine. This is very liver safe. Why is it that it's just never used in patients with chronic liver disease?
I'm not aware of that. I'm sorry.
The reason why I'm saying this is I'm afraid Dr. Akash Shukla is not here.
We are using it as a second line, not as a first line. Wherever all the four drugs can be used safely, they're preferred. However, if hepatotoxicity is an issue, then possibly Terracox can be used.
What about a liver disease like this, wherein you can't use paracetamol?
We can use it, but it is not recommended as a second line, normal second line. The other ones are mentioned, like aminoglycosides or quinolones, they're mentioned above it.
Like,
thank you.
Excuse me. One just question to the speaker. I mean, in a CTP-AA, can we start off with an SHRE? That's what the other chairperson say.
Start off with
SHRE.
Yeah, so that's another way of looking at it. You start with first two hepatotoxic drugs, and if the patient is doing well, you add the third one. Yes, that can be done.
Yeah.
Or you can start with it. Yes.
SHRE. Yeah. Okay.
I usually do the first thing. I start with two hepatotoxic drugs and add pyrazinamide later if the patient is
without the pyrazinamide regime, only the streptomycin, rifampicin, INH, ethambutol, and streptomycin.
Yes, it can still be, can be used. Yes.
Yeah.
Okay, thank you, sir.
Thank you.
We conclude the session. Since we are running behind the schedule, we are skipping the tea break and we will continue with the next session. So our next session is advances in therapeutic endoscopy. And the moderator for this session are Dr. Manish Kak, Dr. Alok Gupta, Dr. Sanjay Garg, Dr. Vijant Singh Chandel, Dr. Nishant Nagpal. And the chairpersons are Dr. Alok Chandra, Dr. Somil Shah, Dr. Neha Berry, and Dr. Haider Hussaini. And the speaker for ERCP in Altered Anatomy, Tricks of Trades, Dr. Rajkumar Wadhwa.
Shall I? Good evening, dear friends. At the outset, I would like to thank Professor Anil Arora for giving me an opportunity to come here. The topic is ERCP in an altered anatomy. Why is it necessary? We know that Pancreatico-Biliary diseases are best dealt with ERCPs. In a normal anatomy, majority of us can do majority of the times. However, with the conventional equipment in an altered anatomy, there is a very limited success. So we need to understand the kind of instruments we will need to do this in altered anatomy. And because of variety of situations we encounter, there is no standard techniques which can do an ERCP across the spectrum of these things. Over-tube assisted enteroscopy, however, takes the large part of this into its thing. What are the challenges which we face in altered anatomy? First is when we enter from the stomach into the small bowel, we need to understand where the afferent limb is. Then reaching and identifying the major papilla because of the different length of the loop we have. Selective cannulation from the altered orientation. We are actually in the reverse direction, so you will have a difficulty in cannulating. And performing therapeutic interventions with standard accessories can be difficult. With an endoscope also, it can be difficult. So you are looking at changing the whole of the scope as well as the possible. The first step in doing any altered anatomy is reconstruction type, what kind of reconstruction it has been done, what kind of different surgeries it has been, the patient has undergone, and what is the length of the loop which has been formed. It helps for us to understand what scopes to be picked up, and based on the scopes picked up, we will find what accessories will be useful in these situations. Some of the common resection patterns which we find is either a Billroth 1 or a Billroth 2. In a Billroth 1, it's the standard duodenoscope which can be used. However, the difficulty is the stability of this scope is not great. It slips easily, and by repeated pushing, risk of perforation is high. So we need to keep that in mind. Billroth 2 will go into the rest of the tips later. The next common thing is Roux-en-Y gastric bypass and gastrojejunostomy in a different circumstances. Here, the length of the loop is probably the most important criteria for picking up the scope which you are going to use and the outcomes which can come out of it. In Whipple's procedure, you get different thing. While it is similar to what you get it in Billroth 2, except when you have a bronze enteroenteric anastomosis, here the technique is extremely difficult because you tend to keep looping around in the stomach by entering it with the scopes, and the success rate drops further. While liver transplant especially, does not require the altered anatomy status because you use a standard duodenum. In certain situations, you can have the Roux-en-Y anastomosis with hepatico-enteric anastomosis in these circumstances. So keeping all these things, what do we use? What are the procedures which can help us understand which procedure to be done in which kind of altered anatomy? So as I said, in Billroth type 1, you go ahead and do per stomal duodenoscopy with a standard ERCP scope. The other procedures which are there is, the most common one is over tube assisted ERCP, either a single balloon or a double balloon, percutaneous or US guided cholangiographic rendezvous approach, either with an over tube associated enteroscopy or with a colonoscope. So you have the ERCP which can be done with a rendezvous procedure, laparoscopy assisted ERCP, and the H procedure, and last but not the least, but not very commonly done now, surgical proximal stoma creation and pushing the scope through the proximal stoma. While these different procedures have different outcomes, what factors in a surgical anatomy make sure that you have a successful ERCP? When you have a short length of the afferent loop, you have a far wider variety of scopes available to you, and you can perform the ERCP far more times successfully as to when the length of the loop increases. The loop could be 100 centimeters, 150 centimeters, or more than 200 centimeters, especially in a gastric bypass procedures, and the success rate declines with the length of the loop in this situation. So when you have a short loop, you have all the things which can be used. You can use an apogea scope, you can use a colonoscope, you can use a standard duodenoscope, or a short double balloon enteroscope. While in longer, the limitations become far more acute, and you have either an over tube assisted enteroscope. Also, the outcome differences whether you are cannulating in a native papilla or whether you are cannulating in a hepatico-enteric anastomosis. It is easier to enter into hepatic enteric anastomosis. It is far more difficult because what you are having is your papilla is on the lateral side, and you are putting the guide wire in an inverted position. So this is the summarization of what kind of surgery, what kind of scopes we can use. In Billroth 1, therapeutic duodenoscope. In Billroth 2, depending on the length of cannulation. Either you have a forward viewing endoscope of any variety, upper GI endoscope, colonoscope, or over tube assisted enteroscope, depending on the length of the stoma. Subtotal, it is usually a long loop, so you do not have the option of upper GI scope, but enteroscope remains the procedure of choice. In Whipple's operation, if it is a short loop, you can use a therapeutic duodenoscope, but majority of the times you still have to resort onto over tube assisted enteroscope, and hepatico-jejunostomy also with over tube assisted enteroscope. What difference does it make if you choose a single balloon versus a double balloon? Are there any outcome differences? Or if there are different types of surgical procedures? So you can, intubation of afferent limb is probably the most crucial aspect of determining whether you will be able to successfully do it or not. Despite my large experience, I can tell you sometimes it is extremely difficult to differentiate between which loop is afferent and which loop is efferent. And once you enter the afferent loop, you can spend hours together searching for the papilla and you won't get it. And that has to be understood very clearly, because that determines the outcome thing. When you have a diagnostic applications with therapeutic aim, there are certain terms which you need to understand. That is, successful enteroscopy is identifying the papilla by successful cannulation. Diagnostic success is when you are actually taking a cholangiogram or a pancreatogram. And therapeutic success is when you actually perform the procedure for which you have entered into it. All three can be kept into the mind. With the OAE assisted enteroscopy, you can have an access to papilla in about 80 to 90, but success drops down to about 70% of the times. Now, how do you identify the afferent loop? There are methods which we have been described, that it is on the right side. Usually the bile is more in the afferent loop, but there are two different methods which help me in identifying this. That is introduction of methylene blue about 10 centimeters proximal to the site of anastomosis, waiting for a couple of minutes and then going down. The loop in which the methylene blue is flowing is an efferent loop, and the loop in which it is not flowing is an afferent loop. A very similar thing which can be used is use an underwater enteroscopy. Go down to the limb, go enter into one particular limb, inflate the balloon, and then use the air. The air the direction will tell you whether you are in afferent loop or you are in efferent loop. And that's how you can determine how do you reach to the site of enteral anastomosis. Various OA techniques, they have no significant difference whether you use a single balloon or a double balloon. I won't go into the details of it as limited times. There are some other techniques which we need to understand, like edge and lap assisted ERCP. They are primarily limited to Roux-en-Y anastomosis, where the success of lap assisted ERCP and edge procedure is higher as compared to the OAE assisted enteroscopy, especially with the longer loop procedures, because longer loop reduces the success rate, and hence in that situation, when you have a 150 or 200 centimeter loop, it is worthwhile if you have enough supportive, either a surgeon or an endosonographer who can do these procedure, can enhance the success rate in that situation. Just a short thing about short double balloon endoscope. Long double balloon endoscope is about 200 centimeters. Accessories are very difficult. Short double balloon enteroscope overcomes this and has been specifically designed for the ERCP in this situation, and has a significant problem. Few other things which we need to understand, that this is an ERCP of removing a stone. The catheter which should be taken should be straight tip catheter and not a curved one in these circumstances. Always use a cap, because addition of cap increases the success rate by about 4 to 5%, as you can push the wall sideways. Here the guide wire does not come in the direction always when you are coming out, and hence cap helps in making sure that your position is taken care of. I won't go into the details because I have lots of such videos to give you an idea, but you can do now sphincterotomy. You can use double guide wire cannulation techniques as you use it into a standard endoscope. If you inadvertently can cannulate a pancreatic duct, you can go into the bile duct, or if you cannulate the bile duct, you can go into the pancreatic duct. You can use the sphincterotomes, which are designed specifically, and hepatico-jejunostomy stricture with cholangioscopy, if required, can be done using a double balloon endoscope, where you make sure that you do not put the balloon on the scope. Just use the balloon of the overtube, go next to the papilla, go next to the hepatico-jejunostomy area, dilate that area, remove the scope. Do not remove the scope with the balloon kept on the scope, because balloon will be slipped off. You remove the scope and put a cholangioscope through a standard thing, and you will be able to do a cholangioscopy. Placement of metal stent is possible now with short double balloon scope, therapeutic type, which is about 2 centimeters. There are now plenty of literature available that short double balloon scope scores over long double balloon scopes in the altered anatomy situation. We have our own experience, a small one, but we found that probably this is one of the best procedure when your loop size is between 100 and 150 centimeters. Beyond 150 centimeters, you have to use a rescue technique in these circumstances. So ERCP in altered anatomy is complex. Pre-procedure planning helps in correct choice of instrument selection. OAE ERCP remains the preferred modality. Short double balloon scopes overcomes the technical difficulty of stabilization of long scopes, and use of standard accessories is there. LA ERCP and edge seems to be superior to OAE in bariatric surgery, RYGB with long loops, and in all other cases, short double balloon scopes should now be the preferred instrument of choice, with long OAE as a rescue procedure. Thank you very much for your kind.
Just one question, like when we use upper GI or colonoscope, how do you compensate for the absence of elevator? I mean,
you can't. That's what I said. Use always a cap for it. Okay. Cap helps you to give you a vision of about 3-4 millimeters. With the wall can be pushed. You have to move the scope to the side to push the wall and bring the papilla in the center. So okay. Cap pushes the wall aside and papilla pops into the center of the.
All right.
Suppose we have the routine ERCP complications, bleeding, and also the coy grasper and other things. How do we manage that?
All complications to be managed in the same way as you manage it in ERCP. Only thing is, you will not have the access. You have to make sure that your accessories are correctly placed, and that is where short DB comes into a better situation, because all the standard accessories can be used with the short DB, but not with the single balloon or double balloon scopes.
Right. Any other questions from the audience?
So we conclude this session. Thank you, sir.
Thank you,
panelists and chairpersons. Coming on to the final session of the day, liver clinics by Dr. Patrick Kamath. So I would like to invite Dr. Patrick Kamath to please begin the session. And the panelists for this session are Dr. Charles Panakkal, Dr. Narendra S. Chaudhary, Dr. Arun K. Sharma, and Dr. Amit Agarwal. Yes. Dr. Charles.
So good evening, everyone, and again, thank you to Anil and to Ashish and to Praveen for inviting me to this presentation. So we have only 30 minutes, and I thought I would go over liver masses. So before we discuss the cases, we'll go over the general approach to liver masses. So take-home messages, there are 3 categories of liver masses. Okay, anytime you say liver mass, find out which of the 3 it is. Benign, requires no further intervention, you manage, you don't need to refer to anyone. There's a second category, again benign, but you require further investigation, requires treatment, and you can usually manage. The third category is the malignant masses. Those require multi-specialty consultation. Always a question is, when do you biopsy a liver mass? Always ask yourself, will it make a difference? When will it make a difference? If the imaging is not so clear, then you need a diagnosis, or for prognosis, it makes a difference, or if it affects management. So if it's going to answer yes to any of these questions, then do a liver biopsy. Otherwise, you don't need to do a liver biopsy. There are some small risks with liver biopsies. We know hemorrhage with mortality about 0.1% in cancer. So it's not a zero risk procedure, the biopsy. Additionally, 2% risk of needle tracking, so the tumor can get implanted. And remember the false negative. If the biopsy is not correct, the patient and you think this is not cancer when the patient might actually have cancer. So remember these things about a liver biopsy. Next take-home message. If a lesion looks malignant, it's much more likely to be metastasis than primary. So that's your take-home message. Primary neoplasms are less common. Hepatocellular cancer is the most common. So most common primary malignancy, but that's in a cirrhotic liver too. So no cirrhosis, malignant looking mass, think is this metastasis, because that's going to be much more common. But you also get cholangiocarcinoma. There are other rarer tumors which have specific characteristics, and then lymphoma too. We'll go over some of these in a little more detail later. Now, these are the general radiological approaches to liver masses. You have ultrasound. If you don't get an answer, you can consider CT scan or an MRI scan. Let's go first to ultrasound, and the first case is going to be ultrasound-based. When you have an ultrasound, the report will either say solid, which can be hyperechoic, which means it's going to be more white and brighter, and that is because of multiple interfaces. Or it can be hypoechoic, which means it's much more likely to be solid. Or it can be calcified, where you can see the you can see the acoustic window there, the shadow. Or it can be cystic, where the posterior wall becomes more prominent. Again, I'm going to show you more pictures of that. Okay, so this is a hyperechoic, brighter than the rest of the liver. Okay, so this is your first case. So this is a 38-year-old woman with that mass. She's overweight. She has vague right upper quadrant pain, and therefore the ultrasound was carried out. So that shows hyperechoic. Physical examination, you see only obesity. Liver tests and AFP are normal. Father died of HCC, complicating MASLT, and she's very anxious. So are you going to tell her, who's going to tell her this lesion is benign? Malignant? I would be more worried about malignancy if hypoechoic. Good. And less worried if it's hypoechoic. What are you going to do next? What's your most likely diagnosis here? HCC, focal nodular hyperplasia, hepatic adenoma, focal fat, hemangioma. Okay, more for hemangioma. I agree. What's your next step here? This is a 38-year-old anxious patient who's obese. Looks like hemangioma, I agree. What's your next step? Who wants to do a CT scan? One. MRI? PET scan? Biopsy? Other? Okay, panel. Who's Charles? What do you think?
So,
what's your most likely diagnosis?
likely to be a cavernous hemangioma.
And what are you going to do next?
Either a CT or MRI.
Why? If it's hyperechoic, no, I'm going to show you
No
some.
halo.
Nothing.
Yeah.
Why do you want to do a CAT scan? I'm not disagreeing. I want you to know why.
Because to confirm a diagnosis of hemangioma, because patient is anxious, father has HCC.
Good. So that certainly means you need a little more proof. And is there a problem with ultrasound hemangioma in a obese person? That is the question.
Yeah, visualization of mass in obese.
So we could visualize the mass quite well. So we
It could be a focal fatty fatty infiltration also.
So this is the problem. A hemangioma is hyperechoic. A fatty liver is also hyperechoic. So your differentiation is a bit of a problem in that. So generally ultrasound good enough for hemangioma, obese person not enough. And of course, this is someone who's very anxious, you need a little more. So I agree. So remember this, hyperechoic masses. Cavernous hemangioma, hyperechoic means multiple interfaces. So the texture in the mass is different. So it's a hemangioma, focal fat, but don't forget metastases, because metastases, which are vascular, colon and neuroendocrine, are going to be hyperechoic. So look at this again. So this is hyperechoic. So you can see it as white, but this is hyperechoic with a target sign, okay, around that. So if you look at this here, you can see that dark area, and that is the halo sign. So that is hyperechoic masses. Hypoechoic masses, remember, always be worried, always consider biopsy in these patients. They can be metastases, they can be hepatocellular cancer, hepatocellular cancer, hypo or hyperechoic. Whose turn is it next? Narendra?
Hypo.
Or hyper?
Hypo.
Very good. Can you make that better? Can you use the microphone?
The larger tumors, smaller tumors tend to be hypo.
Why?
And because of the blood flow.
Correct. So hepatocellular cancer is hypoechoic when it is small, because it is not that vascularized, but as it gets larger, it becomes hyperechoic. And then lymphomas tend to be hypoechoic. So this is your take-home messages from ultrasound. When you see an ultrasound, if they say hypoechoic, bad, consider biopsy. If they say hyperechoic, generally not bad. If it's no cirrhosis, it's not bad. If it's cirrhosis, likely bad, hepatocellular cancer. If it is a halo, bad again. Okay, so that's your take-home message from ultrasound. Now let's go to CT scan. CT scan has different phases, and towards the end I'm going to give you the cautions about interpreting CT scans. So the best CT scan will have a non-contrast, a late arterial, a portal venous, and a hepatobiliary phase. So this is a 4-phase CT scan. Now these are the lesions according to the phase. Okay. Let's say arterial phase, hemangioma most common. Arterial phase lesion you'll see. Show of hands. Only 2, 3, 4, okay. Portal phase, lesion appears dark, may be malignant. Delayed phase, so delayed brightness, typical of HCC. Sure, okay. Whose turn is it now? Narendra, you finished, right? Okay. So who's Arun? Is it your turn? True or false? All I want is...
In delayed phase, typically in the hemangioma, there should be centripetal filling, not...
No, do you see it bright in the arterial phase?
Yeah, we see it bright in arterial phase.
And that is common, so that is true. Portal phase, dark lesion, may be malignant. I'm not saying it is. May be malignant.
May be malignant.
True. Delayed phase.
Delayed phase. It should be. It should not be brightness.
So true of
delayed brightness is in hemangioma rather than in HCC.
So is it typical of HCC?
No.
Okay. So these are the different phases that you have. The arterial phase gives you about 20 to 30% of blood flow. Then you have the venous phase. The portal vein supplies hepatocytes, remember. So normal liver is white in the portal venous phase. And then normal liver with bile will continue to be visualized in the hepatobiliary phase. So normal liver will be white in portal, white in hepatobiliary phase. Okay, so according to the phase, most common lesion which is bright is a hemangioma. Portal phase, dark lesion may be malignant, and HCC is arterial enhancement. Delayed enhancement is typical of cholangiocarcinoma, not hepatocellular carcinoma. Again, I'm going to show you pictures of this. So, another take-home message. If you see a report which says arterial enhancement, this is your differential diagnosis. HCC, hemangioma, which is the most common, focal nodular hyperplasia, and hepatic adenomas. Hemangiomas, don't worry about. FNH, do not worry about. In the portal phase, remember I said portal phase, the whole liver looks white. So anything which is not normal liver will look dark. So metastases will look dark, but cysts and abscesses also will look dark. Then you have the delayed phase. The delayed brightness is typically cholangiocarcinoma. Normal liver will retain brightness, but it gets enhanced in cholangiocarcinoma, and scar tissue also enhances. So that's a benign cause for delayed enhancement. So is that clear? So this is our initial approach before we get to the cases. Okay, so let's go to the first case. Clear hemangioma. They're common, more common in female, can be multicentric, no risk of rupture or malignant transformation. So Charles, what are the indications for surgery in hemangioma?
Giant hemangioma that is symptomatic.
And symptomatic you mean?
One could be pain.
Pain is usually the most. Rupture?
It's rare unless there's a direct trauma or a...
Correct. So people are always worried when they see hemangioma, it'll rupture. These don't rupture. They're very low pressure, except for trauma. I agree. So pain is a problem. Any platelet count, hemoglobin?
Yeah, hemangiomas can have thrombocytopenias and hemolysis.
Correct.
So
it's not common, but they occur. So those will be the only indications for treatment. So this is what a hemangioma looks like. This is diagnostic. And I think Narendra or Arun, you're talking about delayed. So this is a typical hemangioma, fills in from the outside.
Of interventional surgery, is size is not a criteria for surgery? If there is a big hemangioma, then
not an indication for surgery. Not an indication. Size is not an indication for surgery, and we'll come into that in a minute. So you can see it fills up. See that classic? That is the hemangioma, same density as blood, as the IVC, fills up from the outside. And if you look at the MRI, where you can do many more pictures, you can see how it fills up from the outside. So management, do nothing. If they're asymptomatic, do nothing. Surgical resection for pain, sometimes it's difficult to know whether it's causing pain or not. If the diagnosis is uncertain, and the Kasabak-Merritt syndrome, where they get thrombocytopenia and hemolytic anemia, are not very common, but if that occurs, that's an indication for surgical resection. Next benign lesion is focal nodular hyperplasia. More common in females, again, multiple. And focal nodular hyperplasia is normal liver because of more vascularity. So any condition where there's liver blood flow which is irregular, think of FNH. So portal vein thrombosis, if you see a mass, more likely FNH. Budd-Chiari, more likely FNH. Congenital heart disease, more likely FNH. So this is the typical appearance of focal nodular hyperplasia. Early arterial enhancement, but remember it is normal liver. So in the portal venous phase, it will look just like the normal liver. And in the hepatobiliary phase, it again looks like the normal liver. You see, it almost disappears completely. So look in here, arterial phase, it's bright. Portal phase is becoming iso-intense, and the hepatobiliary phase, you can barely recognize it. Okay, but it retains intensity. So patients will ask you, because FNH is so common, they'll ask you questions. Will it grow? You say yes. It grows minimal. Malignant potential, 0. So don't worry about it. If they're on oral contraceptives, should they stop? No need. Serial imaging, no need. Once we see FNH, no further imaging for them. And biopsy, only if the imaging is not characteristic. So if the imaging is characteristic, no need of biopsy. They're okay to have pregnancy too. Simple cyst, that gets on to our next case, okay? So this is an asymptomatic 7.5 centimeter cyst on MRI. 2 years ago, it was 2 centimeters less. So it has grown 2 centimeters in there. Who wants to aspirate? Anyone? Aspirate and ablate. Fenestrate, which is that the surgeon makes an opening. 1 for fenestration. Excise. Other. What do you think? Whose turn? Charles? Narendra?
Surgery if symptomatic, no symptoms, no surgery, no intervention.
Good. Remember, no symptoms, no intervention. Forget the size, no intervention. So typically on ultrasound, which is the best investigation for a cyst, so on a CAT scan, which many times is the first investigation done, looks like a cyst and you're not sure, get an ultrasound. So you can see on an ultrasound, sound waves will go through the fluid, the solid liver will block it, so there is through enhancement, and the posterior wall looks very clear. And you can see here, no internal echoes, no Doppler, which will tell you this is fluid, it's not solid. So if you're worried about a cyst, get a Doppler also at that time. And usually no septa. So complex cyst, on the other hand, will have septae. You can see there, can have thickening of the wall, it can have nodules. So all these would suggest a complex cyst. Remember, hepatocellular cancer can occasionally be cystic. There are metastases like melanoma, which can be cystic. So this is the approach to hepatic cyst. Thin wall, smooth lining, no septa. That's a simple cyst. If none of these, if it's a thick wall, nodules, that becomes a complex cyst. So the first question is it simple or complex? Simple cyst, no symptoms like our patient, no follow-up. You don't even need to image them again. If they have symptoms, you're sometimes not very sure. If you're strongly considering that the symptoms are related to that, you can do alcohol ablation or you can do surgery. But sometimes you're not very sure. So then you aspirate the cyst to collapse. If you aspirate the cyst and the pain goes away, then you consider alcohol ablation. But if the pain does not go away, then you have to really look for other causes. I was given only 30 minutes. At the end, we'll have time for discussion. Please. I was told to stick to the time, so. And then there's focal fat change. So you can see focal fat. This is a picture that I showed at INASL. This is a patient who was referred to us from India as a gallbladder cancer. But you can see here, first notice that it's geographical. It is not round, and there are blood vessels going through it, and it's towards the falciform ligament. So this is hyperechoic on ultrasound. So hyperechoic is, Arun, remember, fat or multiple blood vessels. Okay, that's the most common. So then you have to do an MRI. So if you're looking fat, ask for in and out of phase. Out of phase is, you can know out of phase when it's dark like this. So fat becomes black in out of phase. So white here, black in out of phase. Remember the mnemonic, iron in, fat out. So iron is black in the in phase, fat is black in the out phase. And so just with weight loss, you can see completely resolved. Now you are going to see focal fat because it's common. Remember, geographic and near the falciform ligament, it's associated with obesity, diabetes, high alcohol consumption, and altered metabolism due to chemotherapy. Now, benign lesions requiring further investigation and treatment are a hepatic adenoma, usually asymptomatic, but it can rupture, and it ruptures, cause hemoperitoneum and shock. If the patient is on oral contraceptives, you withdraw oral contraceptives, that can resolve, and the risk of malignancy is if greater than 5 centimeters. So this is the typical hepatic adenoma. It tends to be heterogeneous because hepatic adenomas have fat, hemorrhage, and necrosis. So it will be heterogeneous. So when you see a heterogeneous mass, think of a hepatic adenoma. So seen in the arterial phase, but because it is not normal liver, you can see in delayed phases, it does not retain contrast. That's what differentiates it from FNH. So it's heterogeneous arterial enhancement. It may be iso-intense on portal venous phase, but decrease intensity. That makes it a hepatic adenoma. So those are the features of hepatic adenoma. Here's another patient. This is a 48-year-old male. Arun, I think it's your turn. Fever, jaundice, and weight loss. Okay? So for the audience, which test will give you the diagnosis? Hydatid serology, 1, aspiration and biopsy, 2 or 3, MRCP, some more, ERCP, PET scan. Okay, what do you think, Arun? Why? It's got some cystic component, got fever. So what will MRCP show you? You're worried about the duct? Will it give you the diagnosis though? I love needles. I like needles. So this is hepatic tuberculosis, okay? So hepatic tuberculosis can be miliary, it can be tuberculoma, it can be an abscess like this, and there's biliary tuberculosis. So this is what you need to know about tuberculosis. So miliary tuberculosis, nodules there, tuberculoma, 3 centimeters, hepatic abscess, and biliary. Remember, there is nothing specific about tuberculosis. It's the entire picture that you have to try and put together. And my guess is if you did an MRCP, you would ultimately still probably go for a biopsy. Okay, diagnosis, Charles?
That looks like a head.
Good. What is that? Membrane floating.
Floating DILIs.
What's it called? The exocyst or endocyst? It's the endocyst.
Endocyst.
Okay. So how do you treat these patients?
With
medically
albendazole.
Treatment is good. Let's assume there's no other problem. Medical treatment.
With albendazole.
Good. How long?
I'm sorry.
Good. And albendazole, how long? Anyone albendazole, how long? 3 months, 6 months. Fasting or with a meal? Loudly? With a meal. Good. So this is this is the water lily sign. Remember, albendazole needs fat for absorption. So if you want systemic effect of albendazole, it is with the meal. If you want albendazole to work in the intestine for helminthic disease, then it's fasting because you don't want absorption. Okay, these are simple things you should tell a patient. So here's our approach. This is a complex cyst, agree? Patient has fever, likely a pyogenic abscess, amoebic abscess, actinomycosis, infected hydatid cyst. This is for medical treatment. Consider aspiration and use whichever agent is infectious. If they don't have fever, then you're a little more worried. It may be a different type of tumor, and typically you will require biopsy or surgery. Finally, malignant lesions. if a patient has cirrhosis and you get a mass, that's hepatocellular cancer. Once you've ruled out hepatocellular cancer, the next diagnosis you think of is hepatocellular cancer. Be very careful in these patients. Only then think of a regenerative nodule. So, as we said, as the tumor grows, it gets more arterial supply and becomes hyperechoic. So, high index of suspicion, more common in males, AFP poor sensitivity. So don't be dissuaded by a low alpha fetoprotein. That's another take-home message. The classic is arterial enhancement, portal venous washout, and a pseudocapsule. So you can see this is the picture. You get an arterial enhancement very quickly in the arterial phase. So it's part of the delayed arterial phase that you're going to get that. And then you get the washout. So you can see arterial, portal venous phase, and delayed washout. So that's very typical of HCC. So this is the management. Consider resection if in cirrhotic, in BCLC 0, that is less than 2 centimeters, no portal hypertension. Non-cirrhotic, even larger tumors you can resect. Stage A, liver transplant, tumor ablation less than 3 centimeters if they're not transplant candidates. If they're stage B and good hepatic reserve, transarterial therapy and chemotherapy for BCLC stage C. Now, there are some common mistakes. When you get a CT scan, it's typically not. It's typically a portal venous phase, so lesions are missed. So if you're serious about a liver lesion, get a 4-phase CT. Next, patients have symptoms, you see something on the liver, mistake is to say, the symptom is caused by the problem in the liver. No, remember, dyspeptic patients can have liver cysts. On the other hand, in cirrhosis, you see a lesion and you say, this is not HCC. Always be suspicious of HCC in these patients. And for young patients, once you know it's benign, don't do over-testing. Over time, you don't want radiation accumulation. So, patient has symptoms, mass and physical examination and lab tests, imaging, ultrasound usually, so this is your approach. And if there are atypical features on imaging, you'll get a CT scan or an MRI, and you may consider biopsy. But if the imaging features are characteristics, and we'll go one by one. So Charles, early peripheral enhancement with late fill-in, diagnosis and treatment.
What is it?
This is a cavernous hemangioma, no treatment.
Can't see from
Stellate scar, arterial enhancement, early return to normal. FNH, no treatment. Rapid arterial enhancement, inhomogeneity, isointense on venous phase, hepatic adenoma, treatment accordingly. Anechoic, water density bright, benign liver cyst, aspirate and sclerosis, only if symptomatic. Cirrhosis, arterial enhancement, portal washout, what is this?
HCC.
HCC, treatment according to stage. Delayed washout, delayed enhancement, no washout, what is this?
Cholangiocarcinoma.
And treatment according to stage. Thank you. Now we can have questions, if you have time.
Good evening, sir. Sir, I have a question. In a case of a patient with liver as well, in a CKD patient who is not on dialysis, what would be the best modality other than the ultrasound, either a CT or an MRI?
Yep.
And here I have seen the contrast you are using, the MRI, a different contrast. Here we use gadolinium. So what would you go for it without dialysis?
Yeah, so the question here is the patient has renal failure, not on dialysis. Once on dialysis becomes easier. So they've got a lesion which is unclear on ultrasound. So between the CT and MRI, we prefer MRI, but we always ask our nephrologist because the dermatosclerosis is not that common. So we'll always check with that. Or we will get contrast ultrasound, but often in these patients, the only solution is a biopsy, because your imaging is not going to be good enough. because you cannot give contrast, you don't know the diagnosis on ultrasound, you do a biopsy in these patients.
Often I would take the reference from the nephrologist, but the nephrologist would refuse the MRI because of fear of systemic nephrogenic sclerosis. Then one have to go for the CT then.
Yeah, so if you cannot do an adequate imaging and you need to know, especially malignancy, that's where the biopsy comes in.
Thank you, sir.
So there is one entity, confluent hepatic fibrosis. So any particular imaging features, because many times it mimics like a HCC because the enhancement pattern.
So this is a good question. So the question is confluent hepatic fibrosis. So confluent hepatic fibrosis you see with massive loss, you see it with drug-induced liver injury, and typically it's nitrofurantoin which causes it. So one of the things you see is because it goes along a sector, so you'll see capsule retraction. That is one of the things which shows. And remember, it's fibrosis. So MRI delayed. Remember I said delayed contrast enhancement is cholangiocarcinoma or fibrosis. So you'll see it best in MRI delayed.
Thank you, sir.
Sir, in two of your cases, I will make a differential diagnosis of alveolar hydatid in one case and fasciola hepatica in another case. You didn't discuss those two entities.
Yeah, so the question is fasciola. So I don't see a lot of this. So fasciola is, you can see cystic lesions in there. I don't have an image. I haven't seen one for a long time. So I don't know anything characteristic. Okay. Anil, can you help out with that? What do you see characteristic on the imaging which says this is fasciola?
Yeah, I think one of the differences, if you have too many cysts, especially if the involvement of the lung is there, and if you're not responding to conventional albendazole, that is something which we think of fasciola.
Fasciola, is it? Okay. Yeah, I don't see fasciola, so I don't know.
I've seen two cases actually, maybe 2 years back. They exactly presented with fever, weight loss, and the only clue was that they had some eosinophilia. And the FNA was done, and the lesions are exactly what you showed that tuberculosis patient. It was exactly like that.
So VLM is generally geographic lesion, not round lesion. Generally, it is solid, not cystic, and with lot of eosinophils on biopsy.
You can have, it can be multicentric. You know, you have to see how the fasciola goes to the liver. Once it creeps here, you can get multiple lesions in the liver. And in fact, the radiologist reported that as secondaries, this patient. And finally, we did an CT/MR, and we found some thickening of the bile duct. And the diagnosis actually finally came by the ERCP. Once I did a papillotomy and I ballooned out, it was the fasciola hepatica. And everything disappeared after the treatment of, single tablet of trimethazole, what we give in these patients.
Because I think the alveolar hydatid, which you see in Europe, in Austria and all, which is at the hilum, that looks just like a cholangiocarcinoma. It looks like PSC with intense. So that's different. Do you see it here?
No, very rarely, sir.
Very rarely. Yeah. I was wondering whether you see it in higher areas of Himachal or...
What Dr. Jattu was referring, we see a lot of patients coming to us from the hilly regions, especially Uttarakhand, in which they come with multiple masses in the liver and extensive eosinophilia. You put in a needle and you have basically inflammatory exudates. You are not able to establish the type of parasite, but majority of these do respond to albendazole or praziquantel. We still do not have facilities for toxocaracani serology still with us.
But that also sounds to me like alveolar hydatid.
Yeah, the difference is in alveolar hydatid, most of the time there will be lung involvement. These patients are primarily
I see. This is without lung involvement.
Without lung involvement. Okay. So two things. We recently had 3 patients with huge hemangiomas covering almost major part of the liver, and they were not fit for surgery. So we did an angiographic embolization with injection of sclerosing agent. So they did well. So that is an alternative to surgery in symptomatic patient. As I said, irrespective of the side, as you very rightly said, you do not need to intervene.
Yeah, no, I agree. Is Harshad here? So there was a very interesting patient, I think it's from Mysore, who had a huge hemangioma, and that was resected. So left with only one lobe, and that was almost completely filled with the hemangioma again. So of course there's no surgical option in there. Embolization, she had a complication after that, and Harshad contacted me, and we suggested bevacizumab for this patient to prevent. It decreased in size a little, but her symptoms got better. We went in there. The problem here is you have got hemangiomas, then you get hemangiomatosis, which tend to be multiple small, more in children. Then you get epithelioid hemangioendothelioma, which can be malignant. So this is the spectrum. And so in between, you have to be a little careful.
And in a patient with cirrhosis, at times you have a problem of trying to distinguish between HCC, especially in a centrally located lesion, between an HCC, cholangio, or a mixed hepatocholangio.
Yeah.
So how much does the CT or other radiological interventions help? At times, short of biopsy or contrast EUS, it's not easy to distinguish.
No, you're right. So now it's recognized about 2% of all so-called hepatocellular carcinomas are mixed cholangio-hepatocellular cancer in there. So the treatment currently is like a hepatocellular cancer in there. They can be difficult to differentiate on imaging. It requires a biopsy. You suspect that when you do chemoembolization in these patients and it is not disappearing, because it's not arterialized as much as the HCC. So you try 2 sessions and you see the lesions actually growing, then you say this is probably not HCC, this is probably cholangiocarcinoma in patients with cirrhosis.
One last question.
Yeah. One entity which we
Yeah,
have
just-
started
just-
seeing is visceral larva migraines. We recently had in last 1 year
Oh,
5
yeah.
cases. This present with a long history, low-grade fear of peripheral eosinophilia. And the lesion looks like multilobulated abscess-like lesion. And when we put in a needle, we get charcot-laden crystals. And occasionally we've got an antibody test done, which turned out to be positive, and they responded to treatment. In those cases, visceral larva migraine you should look at. And the pathologist holds the key. They need to see carefully for these things.
So that's interesting. If you look back, maybe in the past 2 months, New England Journal of Medicine CPC is a visceral larva
Larva migraine.
migraine.
So we are seeing more often if we
patient.
search for it, look for it.
Yeah.
That's one entity which we can look at.
Yeah, thank you, sir. And because of lack of time, it can be
Thank you.
winded up. Thank you, sir, and thank you all the panelists and chairpersons for that.
Thank you, everyone. We now conclude the academic sessions for the second day. We will reassemble at 8:30 p.m. for the gala dinner and the comedy night. Meanwhile, Sir Gangaram alumni meet will take place on the UG floor in the strategy hall.